Welcome to Advances in Allergy and Asthma, a webinar series presented by Allergy and Asthma Network in partnership with the American College of Allergy, Asthma, and Immunology. This webinar series helps Allergy and Asthma Network to live out our mission to end needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. I'm Tanya Winders, President and CEO for Allergy and Asthma Network. Today we are joined by Dr. Jay Lieberman. He will discuss the latest in food allergy diagnosis. Born in Memphis, Tennessee, Dr. Lieberman graduated from the University of Texas in Austin before returning home for medical school at the University of Tennessee Health Sciences Center. After graduating from med school, he completed his residency in internal medicine at Washington University in St. Louis, Missouri, and followed this with a fellowship in allergy and immunology at Mount Sinai Hospital in New York City, where he concentrated on food allergy and primary immune deficiencies, staying for a third year to complete research in food allergy. Upon completion of his fellowship, he returned home to work at the University of Tennessee and Le Bonheur Children's Hospital, where he is now an associate professor. He also serves as an associate editor for Annals of Allergy, Asthma, and Immunology, and as vice chair for the American College of Allergy, Asthma, and Immunology Food Allergy Committee. He serves also on the Joint Task Force Practice Parameters. He currently lives in Memphis with his wife and 2 daughters. Dr. Lieberman, thank you for being with us today, and we look forward to your talk.
All right, thank you very much. So I'm going to see if I can take over here.
Okay.
All right. Perfect. All right.
Great.
Can you see the screen okay from there?
Yes, we can.
Perfect. All right. I just wanted to say thank you to Tanya and thank you for inviting me here for this lecture. I do want to go over my disclosures here. You can see those. I do serve for an advisory board member for some pharmaceutical companies, and I do perform clinical research at our institution for some pharmaceutical companies. None of those, however, have anything to do with diagnostic testing for food allergy, and there should be no conflicts of interest regarding the topic we're going to talk about today. So here are our objectives. I'll try to identify tests that lack data to support their use in food allergy diagnosis, to assess the performance of current diagnostic tests used for food allergies, and recognize limitation of current diagnostic tests. And to do that, we'll take a look at the current tests available and kind of go over some proven as well as some unproven tests. And take a closer look at guideline-supported tests that are currently used by most allergists today, and then look into some future possible tests that hopefully will be available down the road, but not currently in everyday practice right now. Okay, so let's start and look at what tests we have available and which ones have good science to back them up and which ones kind of lack that science. Before we go directly into the test, though, and kind of to frame the idea of when we're thinking about diagnostic tests or any therapy within medicine, I think it's important to kind of take a step back and think about what tests should we use or what treatment should we use. And nowadays, you know, the buzzword is kind of evidence-based medicine and shared decision making. And so it's when we think about evidence-based medicine, it shouldn't be here's the data and this is the only thing we're going to do, or I'm the doctor and I say this is where the science is and this is what we're going to do. It rather takes in all of it together. It takes in the available data that has for that therapy, for that test, the physician or practitioner's clinical judgment, and also should include the patient's values and preferences. And you can think about that and say, kind of, if a patient walks into my office and they think they have a food allergy and want me to order test X, If I kind of, in my clinical judgment, say test X is not a good test and there is no scientific data to support its use, you could argue that that is not evidence-based medicine to use the test, and we shouldn't just use the test because the patient wants it. But on the flip side of that, if we're up here, if the doctor's saying you need to do this and I need to order this test, but the patient has no desire, and an example may be a patient who's avoiding a food due to concern of food allergy, and the doctor's saying, I'm not sure you're allergic, my clinical judgment says you're not, and I want to order this test, and this test's going to say you're not allergic and you should eat the food. The patient has no desire to eat the food, and it's not dangerous for them to avoid the food, just let them avoid the food. So when we're thinking about evidence-based medicine, it's right in that sweet spot between the doctor or practitioner's judgment, the data of the test, and whether or not the patient has any desire to have that test done. And so when I think about tests for food allergies, I think about it along a spectrum. And so in my mind, when I created this, there's tests over here that probably have very little to no scientific data for their use, and I would argue probably shouldn't be used. And then there are tests over here that we have very good data for, and if used properly, can help us diagnose food allergies, and then some squishy tests in the middle. And when we plot current tests available, in my eyes at least, it looks something like this. And so I do want to spend a minute on this slide, kind of go over in some of these tests that I consider on the lacking credible evidence for their use side. And I'm not going to talk about them any further after that. But these tests over here that you see, such as kinesiology, in which the patient holds a vial with a food and the resistance of their arm when they're holding the vial to diagnose food allergy. Pulse tests, such as eating a food and measuring the pulse throughout the day and looking for changes in the pulse. And then some of these other tests, such as cytotoxic testing or ALCAT testing, which essentially take the patient's blood and then take a food and then look when the food is put into a vial or into a well with the patient's blood to look for changes in blood cells, changes in shape in blood cells to diagnose food allergy. These tests, some of these tests you can order at home for patients. They don't even need a doctor. And many are practiced by naturopathic doctors. There's clearly a role for some of this, but I would argue the science behind these tests is very lacking. So they lack very well-designed studies to say that they can truly prove whether or not the food is causing the symptom in the patient. The one I most commonly see in my practice is this here called food-specific IgG testing, in which patients can have various complaints, whether it be fatigue or headaches, and feel that the food is causing it. And you can send off a blood test that'll do typically a panel of something like 96 or 112 foods or so. And then they'll give you this big report that's saying your IgG level to food X, such as wheat or dairy, is this, and that's probably causing your symptoms, and therefore you develop a full elimination diet based on that. I would say that the food IgG testing has no role in diagnosing anaphylactic type allergy for sure, and the data on it to detect things such as headaches or fatigue due to food allergy is very, it's not very well designed, and it's very limited for its use. So when a patient comes to me and they've already had this testing done and they ask me, what do I do with this? I tell them, you can avoid these foods if you want, but I have no scientific evidence that suggests this is true personally. And my clinical judgment is, I don't think that these foods are causing your symptoms, but if you want to avoid these foods, it's okay, as long as you're not putting yourself at risk for, dietary risks, and make sure you're getting all your nutrients. And so those are the tests on kind of the side of things that I personally, don't order in my clinic. And then what we're going to spend the majority of our time on the tests on this side, tests that have a little more data to support their use. And I'm going to talk about how we should be using these tests, and then a little bit about some newer tests that don't have quite the amount of data that the standard tests have, but hopefully we'll gain more data and more use as they get more mainstream, hopefully. And so these will be the tests that we're going to talk about here in a minute. So we're going to start by talking about the most commonly used tests, meaning if you go to your doctor and are concerned about a food allergy, this is what allergists will typically do, using skin testing and serum testing. And so how can these tests be used? So, as allergists, we've had data on how to interpret and use these tests now for, over 20 years. And I just showed this older study to give you a visualization of how it probably should be used. And what you can see on this slide is that for 4 different foods, egg, milk, fish, and peanut, on the x-axis for all of the charts is the value of the blood test. So if you think that the allergist or the primary care doctor orders a blood test for peanut, this is what they're ordering. It's an IgE level, and it ranges typically, or most labs, from 0.1 to 100. And once they get the value of 100, most labs just say greater than 100, and they don't give you a value beyond that. And the way to conceptualize it is, as that value on the x-axis increases, the probability or likelihood of true allergy, meaning if we feed that patient the food in question that day, we would expect a reaction. And the probability goes up along the y-axis. So as the value of the blood test goes up, so this, for example, would be as the value for the peanut blood test goes up, the likelihood that that patient is truly allergic if we feed them the food will also go up. And a couple quick things to say about it. As you look on this this one chart, the values differ for different foods, first of all. And second of all, there's essentially very little evidence that there's ever 100%, meaning there are absolutely patients out there right now with values greater than 100 that can eat the food without a problem. So it's not a perfect test. But this is how we should use it and how we should use it to interpret whether or not a patient is allergic if we order this test. The same can be said about the skin prick test. So this is the test that you go into an allergist's office. They usually use a very small lancet or a plastic thing. They kind of scratch the skin and wait 15 minutes. And if the patient's allergic, a positive test will show up with a red bump that looks like an itchy red bump, looks like a mosquito bite. So the skin test can be used in the same manner that the blood test can be used, meaning on the x-axis here, we have the size of the skin test bump in millimeters. And on the y-axis, again, is the likelihood that that patient is allergic if we challenge the patient that day. And you can see 4 different foods: raw egg, baked egg, peanut, and sesame in this study out of Australia. And essentially, I just use it for visualization to show us how should we use the test. As the size of the bump increases along the x-axis, the more likely that patient is to be truly allergic. And yes, in visualization, it looks like you get to 100%, but there's always patients out there with even very large skin tests that can tolerate the food and not have a reaction. So it's never really 100%. And so this is how the test is, what it's meant to do. It's meant to say, the larger the test or the higher the blood test, the more likely the patient is allergic. And it's a detection of whether you've developed an allergic antibody, but may not mean that you're truly allergic. But here is a good picture, a way to visualize the problem with the test. So what this is that this is a sample from NHANES, which is just a large database in the United States. And it looked at random patients, so over 8,000 samples, to look at, can they detect the allergic antibody? Do they have a positive blood test for allergies to these 4 foods: milk in pink, egg in blue, peanut in green, and shrimp in the light blue or white? And they broke it down by age group here for you. And essentially what you can see is that if you just take blood from random people in the United States who are toddlers or school-age people, school-age kids, there's a very high proportion of them that will have a positive blood test. So for example, if you look at all 4 foods as the grade, essentially if you just take any kid out in the United States who's 1 to 5 years old and you just check a panel of these 4 foods, approximately 1 in 4 kids will have a positive test to at least one of the foods, with milk being the most common positive test, and then egg, and then peanut. And so what I use this study for, these data for, is to say, I often use it as an example just to say, if I take out 100 kids out of school right now, 6 to 19-year-olds, right? If I take them out of school right now and draw their blood, I can expect approximately 11 of those 100, or 1 out of 9, to have a positive test of peanut. Of those 11 out of 100, we know, though, only 1 to 3 at most probably are truly allergic to peanut. And so what this tells us is that sensitization, or a positive blood test to a food, is quite common, but the true allergy is much lower than that. And so it's very common to have a positive blood test to a food, but eat the food without a problem. And so we do have current guidelines, current recommendations on how to use tests. And this was a little bit older, but it's still one of the most recent ones. And this is guidelines on how to diagnose food allergies. And I used that prior slide and take one of the guidelines out of this to kind of show you how it's best to use tests, to select and use tests to evaluate food allergies. And you should base that on the patient's medical history and not use large panels of food allergens. Because if you use large panels of food allergens, we know that you're going to get these random positives, which probably means nothing. And I get multiple referrals to my practice in little kids who got the tested done for a questionable allergy, or maybe eczema sometimes. And you get all these positive blood tests, and then there's a lot of confusion. Do I eat that? Do I not eat that? Is it causing my kid problems if I eat it? And typically the answer is no. If the child was eating it without a problem before, they can go on eating it. And a positive blood test in and of itself doesn't mean anything. It must take into account the patient history. So as we think about these tests, we can see that they're sensitive tests, but they're not very specific, meaning they're going to pick up probably everyone who has an allergy, but they're picking up a lot of people who don't have an allergy. And so we kind of start thinking about, well, what are these tests identifying and why are they like that? Okay, so like I said, we have to use the tests in conjunction with the patient history, because they are really just tests of sensitization. And what that means is all they show us is that the patient has developed an IgE, or what we call the allergic antibody, to the allergen in question. But that does not equal clinical reactivity. And we know that from the data I showed you, that it's very common to have a positive test in just random sampling of patients that we know are not all allergic. So we kind of think about the tests we use, like the blood tests, and we think, well, why might that be? And what are we detecting? So if we conceptualize it like this and say, what we're doing is we're adding patient's blood to something with peanut, a peanut extract. Essentially, what you've done is you've taken the peanut, crushed it up, you defatted it, and made it into a protein extract. And then you've added the patient's blood to that and see if it binds, the allergic antibody binds it. What we're doing is we're saying we can detect that you have an allergic antibody that binds this peanut, but we don't really know what it's binding to. And so that may not be all that helpful, right? Because we know peanut, for example, has multiple different allergens or proteins in it. And what we found out recently is that some of these may be more important than others regarding whether that leads to a true clinical allergy. And what we know now, for example, and what we're learning is that some of these are important and some of them not. So for example, with peanut, if you have a patient whose allergic antibody binds this one protein called ARH2, that is more likely to reflect a true allergy that the patient would react if we fed them that food today. But if their allergic antibody only binds this protein called ARH8, maybe they're not actually allergic. Maybe they can eat that food regularly without a problem, and that helps tease out some of this false positive tests for us. And so that kind of gets us to the next phase of food allergy diagnostic testing, which is something called component testing. And the timing of this talk is very fortunate, because just last month, the Joint Task Force for Practice Parameters that essentially comes up with the guidelines in the United States for various things within allergy, just developed a guideline paper on diagnosis of peanut allergy. And just last month, they sent it out to the larger groups in the allergy community, the American Academy of Allergy and the American College of Allergy, to get feedback and to get public feedback as well, to comment on the guidelines, and it will soon be published in its final form. It's not quite there yet, but I wanted to share a little bit of that that new guideline in its pre-published form to give you an idea of how component testing is changing a little bit of how we diagnose food allergy. And so in that guideline, it pooled all the studies that really did a good job of trying to determine the utility of skin testing, blood testing to whole peanut, and blood testing to the peanut component AirH2. And to give you an idea, what we know is that the skin test here, using a cutoff of a 3 millimeter wheal or bump after the skin test, a positive peanut blood test, so a positive peanut IgE, usually the cutoff is 0.35, or a positive AirH2 at a cutoff of 0.35 or 0.1, depending on the lab, essentially says a skin test and a blood test, the way they're commonly used, are very sensitive tests, like we've discussed. They're going to pick up pretty much everybody who's allergic, but they are not very specific. They're going to pick up a lot of people who are not allergic, and you're going to get a lot of false positive tests. And what the component testing to AirH2 can do is it is not as sensitive, because you're going to miss some patients who are not AirH2 allergic. They might have other components they're allergic to. However, you're going to really raise the specificity of the test, and you're going to decrease a lot of those false positive tests. And so AirH2 has refined the food allergy diagnostic world for peanut in a way over the past, let's say, 10 to 15 years. And so the guideline statement in that new practice parameter or guideline document actually gives a recommendation to say we suggest in favor of AirH2, the peanut component, diagnostic testing over skin test or specific IgE to whole peanut in a patient presenting for evaluation of suspected peanut allergy for which a single diagnostic test is to be used, as AirH2 would provide the best diagnostic accuracy as determined by virtue of more optimal positive-negative likelihood ratios. And so what that tells us is, as one of the members on the guideline committee kind of said anecdotally, was, you know, if I had one test to bring to a deserted island, I think I would choose AirH2. Now, in clinical practice, it's never like that. So patients who come to me, clearly I'm still using the patient history, which is the most important part. I'm using skin testing in my practice. I'm using serum blood testing to whole peanut, as well as serum blood testing to the component AirH2. It's not a one or none kind of thing, but it's a nice way to see how changes in diagnosis of food allergy there are changes being made, and it's evolving to include newer testing, and how newer testing is refining how we diagnose different food allergies. So they gave that a conditional recommendation with a moderate certainty of evidence. So just to let you know, there are component testing to other foods. So for example, in the US right now, FDA approved testing for components for egg, components for milk, peanut, and tree nuts. I'm not going to go over all of these. But you know, there's some data, for example, that components for egg and milk may help or determine whether the patient will react if they're given the baked form, like a muffin with egg or milk, or whether if they're more likely to outgrow the milk or egg allergy. What I will say is the data for the other foods outside of peanut are not as refined as peanut, and peanut has the most robust data for the component testing. But it is nice to see how we can refine food allergy testing just with the typical blood test that we use. One other thing, the peanut component or the peanut diagnostic guideline that's coming out kind of introduces to us is this thing called a Fagan nomogram, which I've displayed here. And I'm not going to go too in depth, one slide on this, but what I want to introduce is that when we are sending off diagnostic testing, just like when someone presents to the emergency room concerning for a heart attack and the doctor's sending off blood tests to give them an idea of the likelihood that their chest pain is due to a heart attack, they have to take in the pre-test probability and not just use the test in and of itself in a vacuum. And so the way these things work, I'm just going to give you some made up examples here on how to kind of conceptualize or visualize this, right? So let's just take a scenario A where we have a 2-year-old who's never eaten peanut, who's tested due to an older sibling, and the peanut IgE test gave them a value of 2 kilounits per liter. And these are all patients that I've seen in my clinic. And so what's the likelihood that that patient is truly allergic, right? So we have to take their pretest probability, and we know in younger siblings of patients with peanut allergy, we know that the likelihood that the pretest probability is probably between 1 and 5%. So if we take that pretest probability with a likelihood ratio that's generated by this specific IgE level, you get a post-test probability that's still pretty darn low, even though they have a positive blood test. And so in a patient like this, if they're coming to me, I would suggest that this patient undergo a challenge, because the benefits and the risks and benefits in my mind are definitely in favor of challenging that patient in the office to see if they're allergic, rather than saying, oh, you have a peanut IgE of 2, you should probably avoid it because you have an older sibling. Because if your chances that you're allergic are less than 10%, it's probably worth, I would assume in most patients' minds, challenging that to prove that it's not an allergy. Now, it'll change a little bit. It's possible that you can change the likelihood ratio with a different value. So you take that same patient, but now their peanut IgE is 40. That, we don't have perfect likelihood ratios for every peanut IgE. So I'm making this up a little bit. But if we increase that likelihood ratio on the scale with the same pretest probability, what you can see is now the post-test probability, let's say, is now 20%, maybe 1 in 5 chance that the patient's allergic. And that will allow you to kind of work with the patient and say, if I tell you that there's a 20% chance your kid's allergic, would you want to challenge them in the office? Or is that too high of a risk for you? Because I'm willing to offer that challenge, but it might be too high of a risk. And that goes back to the evidence-based medicine and shared decision-making, that we shouldn't just say, hey, you're allergic because you have this high peanut IgE, but also shouldn't say, I'm not going to challenge you, because the risk is still probably pretty low, not knowing it, with the pretest probability that we have. One final one was definitely a patient that came to me as a kid who wanted to go into the Army. He was 16 years old, and you can't go into the Army or armed services if you have a food allergy right now. And he wanted a second opinion because he had a blood test, the AirH2 that we talked about, that was positive at 2.0. But he's telling me, and he told the other allergists, that he eats peanut all the time. And so then you have to decide what's worth doing. And once again, his pretest probability is very, very low if he's truly telling us he eats peanut every day. And even with a high likelihood ratio, when you can use the Fagan nomogram, it gives you a very low post-test probability. And so absolutely this child was challenged, and he did fine and ate the peanut, no problem, and hopefully went into the armed services. I don't know. But it just goes to show you that we need the pretest probability. The likelihood that that patient truly has the disease is very important to take into account and not use the test alone in a vacuum. So just finishing up the skin test and serum IgE test, some quick pearls and pitfalls if you're a patient who has these tests done, or if you're a practitioner using them, is that number one, the size of the wheal is predictive of the likelihood of a reaction, the presence of true allergy, and that's what we showed in those slides earlier. One thing to say about that is most studies, when they take the size of the wheal, they use what's called the mean wheal diameter, which essentially takes the longest diameter in millimeters and then the perpendicular diameter and then averages the two. So if the allergist isn't doing it that way, you can't take the value the allergist uses and use data that was generated using this. We know that the size of the wheal, sorry, I was supposed to say wheal, does not predict severity. So a bigger, most patients come in and they have a really big skin test. After I test them, they get very nervous that means they're more allergic, and we don't have any evidence that that's true. And not all devices give the exact same wheal size. So if you're an allergist trying to correlate the size in your office versus the size in a study you read, you need to make sure you're using the same device and measuring it the same way. As far as the blood test, the serum IgE test, reported class levels are very arbitrary, and I get this all the time. A family comes in and says, my child is a class 6 to peanut. They're very, very allergic. The class levels are arbitrarily assigned by the laboratories, and they're not used in studies to determine that a class 6 is more allergic than a class 4. The class is just based on the absolute value, and what we showed earlier is that the higher the value, the more likely the patient is truly allergic. But the higher the value does not predict severity. And this has been shown in multiple studies And it doesn't mean that if your child has a peanut IgE greater than 100, that they're more likely to experience anaphylaxis than someone whose IgE is 10, for example. It seems like it would be, but unfortunately it doesn't correlate that way. So we can't use class level or the value of the IgE to predict how allergic a person is. Also, like we talked about, there's no level at which 100% of people react. There are people with levels greater than 100 that eat the food without a problem, and so you have to understand that there's a lot of interpretation that has to go on with these tests. And just for allergists out there, there's some people say that you can use a food-specific IgE, meaning the peanut IgE, and then take the total IgE, a value that's given in another unit of measure. And if you take the ratio, it can help try to predict who's allergic or not. And it's very debatable whether that adds any value to the interpretation. Okay, so with the last about 15 minutes or so, we're going to talk about hopefully the next generation of testing, and hopefully some of these tests will be available in the future. So the first one I'm going to talk about is something called multiplex microarray. So a microarray is essentially, it doesn't have to be used for allergy. It's used in a lot of different diseases and in medicine. And essentially, it's where they're putting microscopic things such as DNA or protein onto the surface of a chip or a slide. And then you can measure multiple different analytes using one sample. There is currently an available chip. It's not FDA approved in the United States, but practitioners or allergists can order it through a specific lab in the United States. And the current microarray chip detects 112 different allergens, 43 of which are food allergen components. And it's nice because it can use a very small amount of blood, only 30 microliters, which is very less than a drop of blood. And so this is what the current chip looks like. Essentially, it's essentially like a slide, and you can see in each of these you would put the 30 microliters of blood, and within this one little square would be the 112 different allergens. So it allows for a large amount of tests to be done in a very small sample, which is nice. And then once they analyze it, the actual lab would get a readout that looks something like this. And what they're seeing is each allergen is being measured in triplicates. So these three dots are one allergen, so that you know that it was replicated and you can get good replicated data. And so all of these represent all these this group is one allergen, this group is another allergen, and then if nothing lights up, they didn't have an allergic antibody to it, and then you can get levels from low to high amount of allergen. And then essentially what they do is then they give you a semi-quantitative number for each allergen. And what that looks like is something like this. And so you would get a report that says, for all these different allergens, environmental allergens, as well as food allergens, this is the value. What you need to understand is this value is not the same, and it's not comparable to the serum IgE value. Like we talked about a peanut IgE of 40, that's not comparable to this ISU, which is the Isaac unit specific for this microarray. And so you can't compare it to the current blood test, the value at least. But what it's nice for is giving you kind of an idea of kind of a sensitization pattern. And I use this as an example. Essentially, we know there are a lot of patients who have positive blood or skin tests to foods, and that positive blood test is due to cross-reactivity with pollen allergens. For example, we know patients who have birch pollen allergy with high values of birch allergic antibody can have positive tests to hazelnut or peanut, and some of those patients will have what we call oral allergy syndrome, so oral itching with various fruits, vegetables, and nuts. And what the microarray would allow is you to group them and get a better idea if that's your patient, meaning, oh, this patient has very high birch allergic antibody, and that's probably driving small positive tests to all these cross-reactive fruits and vegetables. And it would also give you for example, the peanut component ERA H2, which if in a patient like this was negative, you could be pretty confident saying, even if you have a positive whole peanut blood test, it's probably all due to this ERA H8, which we talked about, which probably doesn't likely lead to clinical reactivity. And so the multiplex microarray chip it's a nice addition to the food testing repertoire, but it's not ready quite for mainstream, at least by most experts. It has been studied in specific food allergies. I just want to show you one study to give you an idea. This is in a study of patients who were challenged to sesame, and they had 30 of the 341 patients had data from this microarray. So they had 30 patients who got the microarray done, and they could use the sesame component on the microarray, which is called SES-I1, to see if it helped predict who reacted during the challenge. And this is this analysis, essentially a perfect test goes straight up and across. So the better tests are going to be more looking like this. And what this small study showed was that the blue line here was the best overall test, and that was the SES-I1 from the microarray I just showed you. And they compared that to sesame skin test and the typical sesame blood test you would order. And in this one small study for those 30 patients, it appeared that using this chip was as good, at least as good as the other diagnostic tests, such as the regular skin test and serum test. There's not a lot of data out there on this using this microarray though, so it's still in infancy, and it's yet to be determined whether it's going to ever be used in the mainstream, because it does have some cons. So the pros, as we talked about, you can get a large number of allergens in a single test from a small volume of blood, and it can kind of attempt to dissect sensitization patterns. So you're getting a kind of a more whole picture rather than one single allergen at a time. The problem is the current chip only has components, so you can only put a couple components for each food. So you have to know which is the important component for that food. It gives way too much information, and I've had patients come in with a report, and there's so much there that it's really overload, and you think it would be really good that, oh my God, I'm going to get all this information and I'll know what to do, but then you get overload and you don't know what to do. There is concern that there is a lot of false positives, just like serum IgE testing. And like I talked about, there's not much clinical data for food allergy. I mean, we don't have large numbers of studies where they've taken this chip and said, can it predict who reacts to a food challenge to peanut, like that small study with sesame. The next test that I wanted to talk about is called the basophil activation test. This has a lot of talk about this test in the allergy world, that it's hopefully going to be a really good test to detect who is truly allergic to a food. And the good thing about it is it can be used for venom allergy or drug allergy as well. It doesn't have to only be used for foods. And just to kind of give you an idea of what this test is, essentially it's you're taking blood from a patient, and then you're stimulating it with the allergen in question, such as a peanut in this case, and then a negative and positive control. And then you stop the allergic reaction and you stain it with antibodies. And essentially they have certain markers that will tell the lab which are the basophils in the blood that we want to look at. And then they have markers of when the basophil is activated, theoretically by the allergen. If the allergen is causing the basophil to activate and causing essentially an allergic reaction in the test tube, they can use markers to identify when the basophil is activated. And then they can run this in a little analyzer, a flow cytometry, and tell you, oh, there's high expression of this marker, for example, CD63, which means these basophils were activated and this person was allergic to what we put in. So why use that test? Well, we know that the non-food challenge tests that we've been talking about so far are not great. They have a lot of pitfalls to the current diagnostic tests we use. The good thing about this is it's a direct assessment of physiologic process. Theoretically, you're actively making these cells react, as opposed to an antibody test that just says the antibody is there or not. This test, like the current other blood tests, is not altered by antihistamines, where skin testing is. And it's nice that it can be obtained from peripheral blood, and you're getting what we think are the active cells during an allergic reaction. So this is a review article on how basophil activation tests are done, and it just gives a nice interpretation of how it would look when you got, the result. Essentially what they do is they're adding increasing amounts of peanut extract to the test tube here on the x-axis, and then that expression of that marker of activation on the basophils on the y-axis. So if you had a questionable patient with food allergy, let's say in this case peanut allergy, as you added peanut extract to the patient's blood cells in the test tube, that expression increased, suggesting that patient is truly allergic, whereas another patient may have very low expression of the CD63, suggesting the basophils weren't activated, the patient's not allergic to peanut, and they should be challenged to peanut. And so this is how it would be used, and hopefully would improve the specificity or be a better diagnostic test than we have right now. Now, the basophil activation test has a little more data than the microarray that I showed you as far as actual clinical studies. On the left here is the basophil activation test as compared to skin prick testing, whole peanut blood test, and then the AirH2 component test. And this is in peanut allergic patients who underwent challenge to prove whether they're allergic. And what you can see, like I talked about, the best overall test is going to go essentially straight up and across. And in this one study, the basophil activation test in red was the best overall diagnostic test. But you could argue it's only a little bit better than skin testing, which is much readily available, and maybe skin testing is the best. And then AirH2 performed pretty well. And then the worst of all the tests was just the regular peanut blood test. This was the best study that we have on basophil activation tests in food allergies. There was one other study that's been published that was okay. It was multiple foods. It wasn't just peanut. And just to give you an idea, they compared the basophil activation test to their standard blood test to the skin test. And in their hands, the basophil activation test was the best overall test. So this is encouraging data to say that, oh, this basophil activation test, it may be a very good test to use, but it's not without problems. And you don't have to read all this. I'm just kind of giving you an overall idea that there are a lot of different parts that have to go into this. For example, it's not standardized as of right now, meaning different labs are using different reagents and different markers of basophil activation. So it's not everyone doing the same thing. The clinical utility of it has not been established. It might be way too expensive. It might be cost ineffective to do it depending on where it's done. The blood has to go pretty quickly to the lab. It can't sit around forever like a current antibody blood test can. So that's a negative for it. And then the actual machine, the flow cytometer machine, needs a lot of standardization. So it's definitely not quite there, but hopefully soon it will be a standardized test that we can use along with all the other tests that we have. The last thing I wanted to talk about is not something new, but is the oral food challenge. And it's the gold standard for testing, right? And it should still be done hopefully by allergists across the country. I just want to bring up that there was a nice update to our guidelines on how to conduct oral food challenges. And for allergists, this has a lot of hands-on things to do, kind of how much food to feed depending on the age of the patient, how should I feed the food? Should it be peanut butter or peanuts or whatever? And it gives us how to prepare it from a standpoint. It gives handouts for patients saying, this is how to prepare for a food challenge. This is what to expect. You're going to be in the office at least 3 hours. Bring something the kid will be likely to eat. If it's a toddler and they have a favorite bunny to make them comfortable, bring that or whatever. And it gives a lot of just hands-on things on how to do a food challenge, because this is the cornerstone of how to diagnose food allergy, and it's still the best overall test. So some quick final thoughts before we take questions is I do want to say the oral food challenge is still the best diagnostic test. It's not a new test, but it's still the best. And the diagnostic test is really only useful in the context of the history. If you don't know the patient history, you shouldn't use the diagnostic test in a vacuum. Test characteristics should be considered before ordering a test, right? Everywhere in medicine, we always say, before you order this test, realize what you're going to do with it. If it's positive and you're not going to offer a challenge, you need to know that beforehand. Component testing we talked about can help increase the specificity for some foods, and looks good for peanut. Hopefully, we'll have the basophil activation test in the future as a standardized test that is the same at each lab, and we'll be able to offer another more specific test, hopefully in the future. And those were all the slides I had, and I'm happy to take any questions.
Great, wonderful, and thank you, Dr. Lieberman. That was a wonderful presentation on food allergy diagnostics. I would encourage you again to continue to field your questions in the control panel, and we will get to as many as possible here in the next 10 to 15 minutes. So our first question comes from Marshall, who says, can food allergies lie dormant and then resurface again in adulthood, similar to asthma?
So I think it's important to understand when you say food allergy, what we're talking about. So the classic idea of a food allergy is, this whole, what we've been talking about here, IgE mediated anaphylactic type food allergy. And the classic is, the kid eats the peanut or the patient eats the peanut, and within minutes to an hour is going to develop symptoms that are reproducible, hives, hopefully not trouble breathing, maybe vomiting. And that type of food allergy, as best we know it, doesn't lie dormant and come back in adulthood. Meaning if you're eating a peanut through all your life, it's very, 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 very unlikely that one day in your 20s or 30s or 40s are going to wake up allergic to the food. Now, other food allergies, for example, eosinophilic esophagitis, which is what we kind of call like a slow food allergy. It's a buildup of inflammation in the food pipe. A patient can be eating a food every day and not bother them, but lead to symptoms down the road, for example, of food getting caught up in your throat. And if you remove the food out of the patient's diet, the symptoms can improve. So other types of food allergies, maybe what you're saying, can lie dormant and start to develop symptoms later on in life where you didn't earlier in life. But the classic type food allergy that mainly kind of what we've used today as the model for the diagnostic test typically will not do that.
Okay, great. Our next question comes from Nina, who says, if a 2-year-old was diagnosed with a food allergy to peanuts, how often do you recommend the parents have the child retested? And do you believe this child may ever outgrow his or her peanut allergy?
So we used to say pretty much never. I mean, very, very few patients with peanut allergy would outgrow it if they're diagnosed at age 2. That there's some more encouraging data recently that said maybe upwards of 20% in some cohorts of patients will outgrow it. I'm not that optimistic that the 20%, in most of the patients I see, but I do personally suggest that patients get retested once every year or once every other year. What I tell my patients personally is you don't know unless you check. And while it's unlikely, numbers are against you that a 2-year-old is going to outgrow the peanut allergy if they're truly allergic. It's very low downside to check once every year or once every other year. And what if they are in that 1 in 100 that outgrew it, or the 1 in 5 if you believe the 20%? If they're in that low likelihood, it's worth checking, I think, to see. But more than once a year, more than once every other year is probably not worth it.
Okay, great. The next question is a very interesting one. It comes from Chrysla, and she says, do the results from these tests determine if a person will have a reaction with contact, ingestion of the allergen, or airborne, such as simply smelling the allergen?
No, unfortunately, they can't tell you that. And there are very few studies out there to try to kind of associate testing with those symptoms, and it's even hard to reproduce those symptoms in well-designed, scientific studies, unfortunately. And so, unfortunately, these tests would not be able to do that.
Next question comes from Betty, who says, what's the youngest age that you would attempt a food challenge?
So that's very different amongst the comfort level of the practitioner. And I think, starting now with new guidelines that say we recommend trying to introduce peanut early into diets for high risk infants. So patients with bad eczema or patients with a known food allergy already, we try to get peanut into their diet early. Sometimes that requires a challenge. So in my office, we challenge them down to about 6 months of age. It's not ideal. I don't enjoy infant challenges, but at most, I would suggest that in most academic centers that are handling food allergy, they're comfortable in challenging infants down to 6 to 10 months of age.
Okay. And the next question is a wonderful one and a common one. What is the difference between food allergy and food sensitivity?
Yeah, that's a good question. So food sensitivity or intolerance. So food allergy, just the definition that we use is an immune reaction to a food. And so there's a spectrum of that. The classic we talked about, hives, swelling minutes after eating it, that we call anaphylactic type, or more slow allergies such as, let's say, eosinophilic esophagitis or celiac disease, in which you have an immune response to the gluten part of wheat, right? And then there are all the others that foods cause symptoms, but it may not be immune mediated. The most classic and well described of that is lactose intolerance. That's where, the patient doesn't break down the sugar in the milk. And when the patient doesn't break down the sugar, it goes through their gut, and the bacteria in our gut break down the sugar for us. And when that happens, it produces a lot of gas. And that causes vomiting, severe belly pain, diarrhea. And so that's a classic known description of a food intolerance or a sensitivity. Now, then there's this whole other spectrum of food sensitivities or intolerances that aren't well described. And I don't know what to tell patients who have those or have concerns that they have those, because there are no good diagnostic tests for that, in my opinion. And the only way to know those things are trial and error diets. And unfortunately, it's all patient driven, because you can suggest certain foods, but because every patient's different and because we don't have very good diagnostic tests, the food sensitivity or intolerance all becomes trial and error elimination diet.
Okay. This is a question clearly from an allergist who says, you didn't make mention of any prick testing with foods. What are your thoughts?
So prick testing is best described for fruits and vegetables, usually with fresh fruits. So typically, the allergists that I know that use prick testing are going to use them for fresh fruits and vegetables, in which typically the extract for those, the proteins get degraded in the making of the extract, as best I understand it. And therefore, if you want to know if you're allergic to a fresh fruit, sometimes it may be better to actually take the device that you're going to use for the skin test, literally prick it into the food of question, the fruit, and then prick it onto the skin. And there are studies mostly out of Europe to say that that's better than using the extract that we buy for skin testing for fruits and vegetables. But for the majority of foods, the extract is better than the fresh food. So I don't personally typically use fresh fruit or vegetable, but I think there's argument to be made that if you're going to use it for those things, it's reasonable.
Okay, thank you. Next question. Can any food allergies actually be airborne? For example, shrimp.
Yeah, it's hard to really quantify that. The best studies are in peanut, in which they show as you're opening a bag of peanuts or as you're shelling peanut, after about seconds to no more than a minute, you cannot detect that allergen in the air. Now, if you are splattering something on the stovetop, like fresh cooking a fish or shrimp, can you aerosolize the protein? Because it's the protein that you're allergic to. It's the smell, which is not a protein. You can't be allergic to the smell itself. But the protein, you might theoretically be able to aerosolize if you cook it in certain ways, such as frying on a stovetop. And there are cases, reports of patients who have a fish allergy, are in the room with the fish or the shellfish being cooked, and develop symptoms such as hives or trouble breathing, especially if they're an asthmatic. And so anecdotally, yes, with fish and shellfish specifically, patients tell me all the time, I get symptoms if I'm in the room with it being cooked. It's very hard to prove on a scientific level, but yes, theoretically, if you can aerosolize the protein, then they can go in the air and you can inhale it and cause the same allergic reaction that you have if you ingest it, but it would be more localized.
Okay, thank you. And our final question today comes from Tamara, who says, why do you think that there are so many more food allergies today than when we were children?
We can discuss that on the next webinar, because there are probably a million reasons. The overriding hypothesis, there are two main overriding hypotheses. One is what we call the hygiene hypothesis. So as a species, as we get rid of things like parasites, as we vaccinate, as we don't let our kids eat dirt, and get exposed to it. We are in cities instead of farms where we're exposed to bacterial endotoxins, which our bodies have been used to being exposed to for thousands and thousands of years, that something with our immune system shifts and we develop allergies. And there's a lot of data to support that hypothesis. So the hygiene hypothesis explains a fair amount of it. And then there are the other hypotheses that aren't as well described, such as timing of introduction. We used to tell patients to delay introduction of allergic foods such as peanut, and now we found out maybe earlier was better, and so maybe we brought some of it on from our old guidelines. Or a lot of theories of the way we process foods now, right? Processing the foods may tend to change the way our bodies see them, but there's less data on that than the hygiene hypothesis. But clearly a lot of theories and a lot of different reasons, and it's not one simple explanation.
Well, wonderful response and such a wonderful webinar today. Thank you, Dr. Lieberman.
Sure.
If you will, please advance the slide. At this time, please do go ahead and download the handouts from the control panel. And if you have any difficulties, don't hesitate to reach out to us by email from the links that have been provided thus far. Please do join us next month for our May webinar when Dr. William Silvers will present on cannabis, the effects on patients with respiratory conditions. This webinar will air on Thursday, May 21st at 4 p.m. Eastern. You can register on our website at allergyasthmanetwork.org and also look for our educational link in the horizontal navigation bar. Near the top of the page, scroll to webinars where you can view all of the archived webinars on the page. Visit our website for quality guidelines-based resources on allergy and asthma. And don't forget to access important medical information on allergy, asthma, COVID-19 from our partners and others at the American College of Allergy, Asthma, and Immunology at allergyandasthmarelief.org. Thank you again for joining us. We've had about 900 people on the line today, and we look forward to having you register to be with us next time on advances in allergy and asthma. This is Tanya Winders on behalf of the team at the network. Stay safe and healthy, and have a great day.